the PowerPoint in order to scroll that down for folks?
Yes. I
Okay.
believe if you click on it, they should be able to see it. And anyone who has trouble, just go ahead and type in the chat box during the webinar.
Okay. Thank you, Deanna. So I'm just wanting to give a little bit of an overview today about somatic psychology and how folks that are in service to others through the role of psychotherapy can bring some somatic interventions to your practice without needing to do an extensive amount of training beyond everything you're doing to get licensed. A little bit of the history about somatic psychology. It is an approach to bring the body back into the healing work that talk therapists do. You all have access to the PowerPoint, so I'm not going to read through this. I'm just going to give it to you to look at while we're talking. And if you're interested in the depth of this, you can look at it later. There was a time in history when healers worked with the body, mind, soul as one entity with each individual. And then we went through a period of demarcating exactly where lines were for specializations. And what that has done is created a false understanding about how we work as people. So somatic psychology is wanting to bring the body back into the conversation. And to that end, I'm just wanting to give you a little bit of context for how it is we develop from the framework of somatic psychology. So old school psychology used to think of human beings being born as a tabula rasa. We were born a blank slate, and then we started having experiences. And somatic psychology doesn't really believe that's so. They reference pre- and perinatal psychology as an appreciation of the fact that our mind is really a byproduct, a function of this matter that we inhabit with our soul. And if we discount how we come together physically at conception and how we develop in mother's womb, we're really missing out on a lot of understanding for where we come from, because our brain and our nervous system are developing in the world of our mother's womb, and that really informs the way that our brain grows and our nervous system grows in some meaningful ways. Pre- and perinatal psychology has been around for about 40 years as an organized science, and there are journals available for your review if you're interested in that. There are lots of qualitative ways to get at information about people's experience in the womb, and we also have more quantitative ways. So as kind of a gross measure that I think is meaningful and valid for our work as therapists in the field, a child who is gestating in a womb where the mother is very well supported and emotionally connected, has all of her biopsychosocial needs met. So she has food, she has social support, she's not in a war zone, she's in a safe area. Her neurochemistry is going to be very calm and not so concerned about the future compared to somebody who is not experiencing all of those benefits. So if you can imagine that when a mother is well supported during pregnancy, she can be generating serotonin and dopamine and oxytocin, that those neurochemicals pass the placental barrier and inform the amniotic fluid that the baby is growing in. So the baby is receiving signals from the environment that are fundamentally about safety, having needs met, and this allows the neurochemistry of the baby to grow towards its optimal thriving possibility. If you have a woman who is not well supported, so she's experiencing emotional distress, she may be worried about whether or not there's enough food for her, or whether she's physically safe because of domestic violence or war or other factors. If there is, if she is ingesting toxins, whether through her diet or psychoactive substances, those experiences neurochemically and from the substance level can pass through the placental barrier and inform the amniotic fluid that the baby is growing in. And that will send different signals to the brain and the nervous system that is developing. Dr. Ira Chasnov is the world's leading expert in utero substance exposure, and he has a lot of data about how these different experiences will inform the growth of the baby. And if you imagine that all of our subsequent experiences lay over these early experiences, and the real estate that we have to work with coming in requires a lot of energy to change after birth. I hope that enlivens some compassion and understanding about the great variety of experience that we can have as a species before we are even born. And there is a lot of research about how our physical being will compensate for these experiences if they're less than ideal. So that is a foundation for attachment theory. Pre and perinatal psychology really encourages mindful attachment between caregivers and baby before the baby is born, because that sets up healthy neurochemical cascades for the mother, which informs the baby's experience. And also because it is presumed that consciousness doesn't magically land in the baby through the birth process. Pre and perinatal psychology takes as a presumption, based on some really interesting research with people who know how to talk to babies, that consciousness is in the baby as the baby is experiencing the womb. And so it's not like birth is a magic switch for that. So if we are conscious, then we can be experiencing through a sensory level and at some level also through our neurology what to expect about life. And if we are intentionally cultivating that relationship of support and unconditional love, then the baby is growing up with a different experience than if the baby is receiving signals about not being wanted or not being safe or what have you. And then, of course, those kinds of patterns follow, hopefully, if they're healthy, through the course of the caregiver and child's experience. So taking this microcosm of one individual life and its experiences, if we place that in the context of our whole experience as a species, where we've come from as a species, we are social mammals who are dependent on our caregivers from before birth and through birth and for a very long time before we can live independently. Many animals in nature, of course, are born and basically have to get up on their own feet and be ready to feed themselves, or hatch from eggs, and their parents go away and they just fend from themselves from the very beginning. Because of the size of our brain and what it takes for us to be able to live independently, we are dependent on caregivers for an extraordinary length of time compared to other species. And what that means is we are wired to require co-regulation of our nervous system in order to develop a lot of our brain. We come in with the reptilian brain and the mammalian brain somewhat intact, but they need to continue to grow and organize. And then the neocortex needs to grow. And in that process, we need people who are keeping us safe and fed and attending to all of our needs in order that we can afford the end to develop in our optimal direction. So there are some specific details about how attachment parenting can draw from neuroanthropology to know how to do that if you're interested on this slide. In terms of our work as psychotherapists in the field, something to be mindful of from the attachment literature is that about 2/3 of our species, if we extrapolate out the data that's been collected so far, about 2/3 of our species currently meets criteria for secure attachment, and about 1/3 of our species meets criteria for insecure attachment. And when we have an experience growing up that we fundamentally cannot count on a regulated, organized adult to take care of our needs that we can't even name as a child, if we have that experience enough times, it creates not just a belief set, but some behaviors about how our emotional supplies from the environment that are not organized. And it's very hard to break those patterns. They're deeply ingrained. And in fact, our brain forms around those patterns. So the natural firing of our entire nervous system and neurological experience goes towards disorganization if that's the way that our development was. So in terms of being therapists, we need to bear this in mind, because if we're coming from the benefited position of secure attachment and we're experiencing somebody who does not have that, they're going to be installing in us what they expect from relationship, and we're trying to work with that. We're trying to repair that. And it is my informal guesstimation that the vast majority of people who get mandated for therapy probably fall in the criteria, meet the criteria for insecure attachment. That we're probably, with most of our most fragile clients, really working on some of these beliefs that come out of early relationship and have created patterns that are problematic for this individual with other authority figures and other peers in the world. And so if we don't bear that in mind, then we're kind of putting Band-Aids on these later symptoms and not really getting at the root. So 1/3 is a lot of people on the planet. Something that is hopeful about attachment research is that attachment is not fixed and concretized in the past. It is an ongoing system that happens in relationship, and so it can be improved upon over time. And it is also my not data-supported hypothesis that true psychotherapy, if it's going to be beneficial for most of our clients, the real depth-oriented work that we're looking to do is actually to help clients move toward earned secure attachment. And so if we bear in mind what we need as a species while we are doing our psychotherapeutic work, and we really look at how patterns have this historical context, they don't come out of nowhere, then we can use our relationship to be one of the people that is helping to afford the opportunity for our clients to start moving towards earned secure attachment. And the data that has been gathered in the last 40 years around that is that somebody who meets criteria for insecure attachment can actually qualify for earned secure attachment after 5 years of being in relationship with somebody who qualifies for secure attachment. So we can be that person, or they can have other people in their life that they're relating to on a regular basis. And fundamentally what is happening is that other folks who can self-regulate at an age-appropriate level through all of the challenges that they meet, their nervous system is teaching the more insecure nervous system how to do that through the process of co-regulation. So we've looked at neuroscience a little bit. Another little plug for compassion for us as a species is that if you can imagine holding a baby and how tiny and fragile they are, they don't really have much of their neocortex available yet. They certainly don't have higher executive functioning available because they don't have that real estate. We actually have to grow this part of the brain through experience-based learning. We need a lot of protein. We need a lot of exercise. We need a lot of experiences that are healthy in order for optimal growth of this part of the brain that really separates us from other mammals and lower primates. And that process isn't done until we're 26 years old. So if you can imagine that we have the capacity to procreate in our early teens, but we don't actually have the yield sign in place until we're 26, that explains an awful lot about what we do as a species that doesn't always make a lot of sense. We don't have access to all of the ability to foresee consequences. And so it's why the adolescent parent relationship can be so just rife with conflict, because parents hopefully can foresee consequences that children can't see. But then there's all this energy going towards procreation. It's what our species is meant to do then. And then we have this whole new socioeconomic reality that we have to postpone that process until we're able to really fend for ourselves, which is different now than it was even just a few generations ago. This, I'll be honest, we can take a look at this. Bruce Parry is a world-renowned researcher. Oh, it's not going to the link. Okay. when you get a chance, Google Bruce Perry and look at his images. I'm sorry that's not opening right now. He gives a lot of fMRI brain scans to compare what a brain exposed to neglect from birth to 3 looks like compared to a neurotypical child. And you can just see that the amount of damage that people have to overcome in order to just function is measurable. You can see it. If you think of the brain like an antenna, and that it will have chunks of it that are just not burning, they're not metabolizing glucose, they're not electrically active, it leaves people at a great loss to figure out what everybody else is expecting out of them. So from a somatic perspective, a lot of the work that is being done in psychotherapy is resolution of trauma. And traumatologists differentiate between developmental or relational trauma and what most people think of as trauma, which is single incident shock trauma. So there's some data here about the differentiation. And fundamentally, what we'll talk about in terms of interventions is how do we use our relationship with our clients who have experienced overwhelm or neglect or abuse at the hands of people they were supposed to be able to trust, or they did trust, or they partially trusted, in order to allow that overwhelming energy to leave them so that their body can come back into a resting baseline. When we are distressed, we move into fight, flight, or flee. And we won't go into all of the neurobiology of that. But we have a neurochemical cascade that is less than ideal for our thriving. It is really about surviving when we are overwhelmed by the environment. And when we are very small, pardon me, and very dependent, it does not take very much from the environment to overwhelm us. So we have a lot of these experiences if we grow up in an environment that fosters insecure attachment. And those of us who experience secure attachment have a hard time relating to that. It's hard to imagine that. Your training as you go through licensure will open your eyes to what people experience. And if you can imagine little babies or little children or teenagers repeatedly experiencing a lot of catecholamines, a lot of cortisol, a lot of adrenaline at the hands of people who are supposed to be taking care of them, that is not an ideal setup for this real estate to grow in its optimum direction. And similarly, if somebody is growing up in a war-torn area or in a gang-related area, or they're growing up in abject poverty in parts of the world and then they're forced to migrate just to survive, if we think about all of these ways that the environment is less than ideal for optimum development, you might be the person that is understanding and holding all of that and able with your client to normalize it so that the energy can leave the body. Traumatologists talk about trauma being physiological first and psychological second. We can't get trauma to resolve just by going at the psychology. We really have to help the physiology shift from that defensive or aggressive or frozen posture in order for people to move towards their optimum development. So the research around resilience really shows that it takes one person that we can count on to be there for us in a time of need in order for us to have the capacity to bounce back from trauma. We do have this inborn capacity. And the less trauma we experience early on, the easier it is for us to dip into this well of energy to discharge trauma and bounce back. The earlier that traumas happen, or the more often that they happen, or the more profoundly that they happen to us, the harder it is to find that well of resilience. And so our role as psychotherapists is to be that safe person where someone can come in with a physiological, psychological, emotional charge about something overwhelming that's happened, and they can dump it with us. And if we have certain skills in our body, that can allow their body to resonate with us through co-regulation, and they can drop out what is no longer serving them. So something that separates somatic interventions from regular talk therapy is that we engage the client at a very body-based, body awareness, sensory awareness level, and we use language that references the body so that whatever is being carried in the body does not have to stay there, but it comes into the room and starts its natural process of leaving, which it wants to do, but it's looking for a safe place and a safe sense of direction about how to do that. So somatic psychology talks through pain instead of about pain. We don't talk about pain in a disembodied, intellectualized way. We allow the pain to come into the room and we feel it with our clients. We experience what they're experiencing in their sensory system, and we allow the emotion of that to hit us. And in that process, we are co-regulating them so they're no longer isolated and alone with this. And then in that process, our body is showing their body how to allow this to leave. So this list that you're seeing is just a preliminary overview of some of the different modalities that somatic practitioners use. Some of them are way more based on body first. Others are using the therapeutic relationship and a talk modality first and then go into the body. There's something for everyone. And so this is just for you to, if you're interested, to start exploring some of the different ways that people work. I myself am not trained in a licensed to touch modality like massage therapy. I use mindfulness, I use sensory awareness, I use energy medicine modalities, and I use language talking with my clients. And then I reference people back to practitioners in the community that specialize for different things depending on what's happening for my clients. Or I'll recommend bibliotherapy on some of these modalities, or I'll do some psychoeducation about other modalities. So there are multiple layers and levels that we can work with different modalities to help our clients depending on what's right for them. Some folks really get passionate about a specific inroad in a specific way to work, and they get trained in that particular modality, and then all that come to them use that modality with them. And that is a totally valid way to work. It just depends on your constitution and the type of clientele that you're serving, what is going to work best. Working in the county system for so long, a license to touch was not an appropriate overlap for that kind of a system. So I did not go that route. Those of you who work in an agency setting would not likely go that route. You might be importing somatic modalities through the talk therapy relationship, and we'll get into the specifics of that, or you might be referring people out. And some of you might be really interested in actually getting in there and using contact some different way, being able to have a more physical support method that you use, and then the talk comes along. And that's an interesting thing about the field is many people who are drawn to getting their license to go on to do somatic psychotherapy came from doing body work with people. And they found that a lot of material was arising and they didn't know what to do with it. So they wanted to get the psychological education because their training didn't offer that. Other people work in talk therapy, like myself, find there's so much more that's happening than I was ready for, that I needed to go back and get other training to know how to hold that, but I needed to do it in a way that would serve my clientele. So everyone finds their own method. So this list is just some talk therapy interventions that any of us can use to help a client discharge what they are bringing to therapy. And of course, there are all sorts of books now about different methods. One I wanted to show, let's see, that I really think all folks working with kids and families ought to use. Let's see if I can get this in the screen. Trauma Proofing Your Kids by Peter Levine and Maggie Klein has some really nice, specific, simple language. It's written for the general public, so it's written at an 8th grade level. It's really nice to be able to hand out to families. It gives very specific tools on how to help a child discharge trauma so that they are not carrying it forward with them. And because all psychotherapists who are working towards licensure need to do 500 hours with minors, it's not a bad idea to have that on your shelf and use that if you find yourself in a setting, especially with elementary or middle school kids. But the principles of that carry forward to working with teenagers as well. So we can use questions that bring the client's awareness into their body, or we can use reflections of what we're noticing either in the client or in ourselves that is arising. And if we're doing this in a regulated, attuned way, it allows the client to shift from just telling the story into experiencing what happened when the overwhelming story came in and allow them to discharge it. And this must be the version from yesterday that doesn't have the references posted yet. So I'll send Deanna the one that has all the references so that you can all have that. So that's my initial overview. I'm wondering if we have any questions at this point.
We do. And for those of you who are listening, please go ahead and use the Q&A box to type in any questions that you have for Dr. Roller. Our first question is, what somatic modalities are recommended with children of different ages?
Okay, so some modalities that I really like using, let's go back to this list. Brain Gym is fantastic for helping kids who have to sit still in school for about 6 hours a day, but are having a hard time doing that, and then they come to therapy feeling wound up because they're having to do something that isn't really quite natural for them. So Brain Gym is drawn from educational kinesiology, and there are about 10 books available by the Dennisons that have a lot of the same overlapping principles. So you could pick one or two, one for groups and one for individuals, and have basically everything you need to understand how to help children get their energy to cross their midline so that they can recruit both hemispheres of their brain online and be available for what you want to talk about in therapy. If we start trying to talk with kids before they're actually in whole brain integration, they might not be able to attend to what we're trying to offer them because they might be overwhelmed in their limbic brain. Brain Gym does a nice job of helping to get the electricity to cross the corpus callosum and then get into the left hemisphere so that kids can actually take in what we're offering. So that would be a really nice place to start for someone who's working with kids. And essentially those principles help us to get out of thinking about just talking with kids and actually getting really physically active with them, playing ball, building, drawing, doing things that help get their whole entire body grounded. And educational kinesiology can explain the how and the why of that, so that our time is actually settling their nervous system instead of overwhelming them more, because they're getting talked at all day at school and at home, and there's often no time to just be. So if we can allow their nervous system some space to just be and to be regulated with this safe, organized adult in their world, then when we're talking with them, they can actually take in and digest and process what we're offering. So, did I not put focusing on here? Let's see. Cornell's focusing is right here. So I made sure to put the author's name there so that it's highlighted that way. Focusing is very much a somatic modality. It's about sensory awareness. That can be used with children. It's a simpler form of mindfulness-based stress reduction for children. And that is essentially where the questions and reflections that are listed here come from, is inviting attention to drop into raw sensation, which recruits the reptilian brain to stop assessing for danger and actually experience safety in the body now as energy completes its natural cycle. So focusing is great with children. Body-mind centering is another way to do that. It's a little bit more directive in terms of inviting awareness to the breath and giving direction through guided visualization and things like that. Adventure and experiential therapy is a wonderful inroad with children. It is body-based because these are all gross motor activities that you are doing with a child or a teenager or a family or a group. It's very accessible that way. There are tons of resources online about adventure and experiential therapy. It's also known as experiential education, if you want to look at it that way. And you will find that the data on this kind of intervention is organized for age range, capacity level, developmental abilities, readiness for risk in terms of emotional change, and has a very structured format in terms of being able to plug in a diagnosis and look at different interventions that are really specific for working with diagnoses. So that's a really rich resource for all therapists. Dialectical behavioral therapy is being used a lot with teenagers. For those of you who are getting more familiar with cognitive behavioral therapy, DBT is an easy sidestep to the left of adding more body awareness and body inclusive signals in the process of teaching self-regulation. It's been tested more with kids who are self-mutilating, but now it's starting to branch out into other self-regulation difficulties. So I encourage that very much. And let's see, TheraPlay is another wonderful resource for those of you working with kids. It is a very structured format of teaching parents how to attend to their children in a re-parenting model. So the therapist is modeling how to attend in child-directive therapy so that the parent can see how to be present and attuned and learning to co-regulate their child. There's a fair amount of training involved in that, and it is the go-to method for working with children who have in utero substance exposure. Sandtray is another wonderful method for working with children. It's often nonverbal, but not completely nonverbal, and it encourages sensory awareness by having kids move into the sand and move around the room, choosing the symbols that they want to work with in their tray. And the movement itself, the walking around the room, the choosing, the working in the sand helps to bring both hemispheres of the brain online for whole brain integration. So I strongly recommend getting training in that as well. And one last one that's really nice for kids is heart math. Heart math is uses a little bit of technology, some really simple technology, some of them that are like video games, and others that are little handheld devices that teach children to have awareness of how their heart rate is affecting the way that their thoughts are moving. And so they work with their heart rate to bring it into a resting baseline in order to have the desired outcome in the video game or in the handheld device. The folks that developed this modality are right out of Boulder Creek. They're local here. They're more than happy to work with practitioners getting training and are very available after training in order to do case management with folks. It doesn't take an extensive amount of training to be able to have a handheld device and or the video games that you can take on your laptop with you to the various sites you might find yourself working in. And kids like that, it feels accessible to especially junior high age kids to be able to get on a laptop and sit with you rather than have someone looking at them and trying to get them to talk about their day. So a handful here that right off the bat you could go and get a few hours of training in and be ready to use.
All right, thank you. We have some great questions coming in. The next question is, can I have a copy of the sample interventions for talk therapy? And yes, we'll make the PowerPoint and the recording of today's webinar available, and I'll send an email when that's available on our website. The next question is, can I apply this therapy to patients with cancer?
Oh, interesting. I can't imagine why not. A lot of mindfulness-based stress reduction research is come out of working with folks that deal with chronic pain and terminal illness, as well as just the trauma of a sudden and severe illness. And so if you were to Google Jon Kabat-Zinn and look at some of his YouTube videos, you could just stream Jon Kabat-Zinn in sessions and have him actually lead some mindfulness-based stress reduction in your session and help the client's body come into the most restful baseline that it can. And then people that work with the body can be asking the client to talk about their experience that they maybe don't feel safe talking about elsewhere in their social support system. So all of the symptoms that are experienced with treatment, as well as the illness itself, to give room for the voices, of those experiences in the body in the therapeutic process could be really supportive and helpful. One thing that I think is really helpful for everyone to know is when somebody is in kind of a fragile physical state like that in terms of not feeling well because of treatment, it's really helpful to make sure that the client keeps their eyes open so that they stay grounded in the room instead of closing their eyes and always going inside. That can be overwhelming with the amount of physiological work that is going on in that kind of a state, to be upright and trying to talk and to have the eyes closed. So they don't have to have their eyes open on you if they don't want to, but to have their eyes open in the room and fixed on something that feels soothing for them can be very grounding. It is a practice that a lot of yoga classes use to make sure that people don't just kind of daydream and slip out. And part of that is to not get lost in sensation, but to stay in relationship. Because what happens with folks who are going through treatment for a severe illness like that is there can be a lot of a feeling of isolation anyway. So to get lost in sensation and then not have relationship available because I can't really feel and see and experience you directly can add stress. So we want to keep clients who are overwhelmed in the room with us. And if we notice that they're closing their eyes or really going away like that, we really want to ask them to please open their eyes and stay with us and use that really more supportive, directive voice. But other than that, to use other sensory awareness, just like the list of interventions that's available, encourages bringing attention down into the body where through treatment, people might want to move away from their body and kind of move up into their intellectualization process. This is a way to help discharge all of these experiences that they're going through so that they come to completion. And what I would recommend would be if you have a client with cancer that you are treating, to do a Boolean search, which is phrase plus phrase, right? Looking for perhaps cancer patients plus somatic treatment. And you can look in your area for people that are doing groups that are specific for what your client is going through. And that could be really helpful in terms of normalization, of course, but also to work with practitioners who specialize with folks who are going through a certain kind of treatment, so that you're not having to, invent as you go what would be supportive for your client.
Thank you. Our next question is, how physiologically and neurologically does body awareness help release trauma? Memory is held in the body?
So trauma, when we get overwhelmed with something, we have this whole neurochemical cascade of catecholamines and cortisol and adrenaline. And what that does is the brain just sends all these chemicals down into our large muscle groups in order to defend. So the brain goes into fight, flight, or freeze in the amygdala and some other complex processes that are going on there. But so do the muscles, so does the connective tissue, so does the heart rate. So what happens is the psoas muscle, which connects from the lower back down around the hips and down to the knees, gets ready to run. And then the musculature up here that protects our heart and our lungs and all that goes rigid as well to be able to defend ourselves. But in most circumstances, we are socialized and conditioned to neither flee or fight, right? We're taught not to do that. So what tends to happen is freeze. And sometimes this is called the Possum Response. When we freeze, all of that survival energy gets stored in our musculature and our connective tissue, and it changes our posture over time. We move into a defensive posture, but we can't discharge this energy. So if you think about, if you've ever watched a nature channel and you've seen a prey animal running away from a lion or a cheetah or what have you, as soon as the prey animal gets away from the predator and it knows that it's safe, what it does is it shakes all that racing energy out of its body. And then once that has completed its process, it will be able to drop its head and start eating again. And we know that horses and other prey animals are relaxed when they drop their head and they can start eating. Prey animals cannot do that when they are distressed. They're pulled back. And we do the same thing with our posture. We move into this defensive stance, and if we don't that energy, then it just stays in us. And over time, this creates a rigidity and holding and a tension that does not allow our life force to move as freely. So the physiology of that can't be changed by just changing thinking about it. We can tell ourselves we're safe, but until our body actually discharges all of that stored catecholamine, cortisol, and adrenaline, the brain is still receiving the signal that we're not exactly safe. So over time, this can create for the hyperactive reactions that people have, the hyperarousal, hypervigilance, and it also can affect people's sleep-wake patterns and their sense of safety in regular social relationships where they're not actually in harm's way anymore. It can really slant our perspective because of the stored energy telling the brain I'm still not safe. So when people discharge this energy, then there's this new neurochemical cascade of serotonin and dopamine and oxytocin that changes our heart rate, it changes the way that our blood pressure is moving, and that changes our musculature, and it changes our posture, and it softens us. So you can imagine, I'm sure it's not hard for you to call up in your mind's eye somebody who has experienced a relatively privileged life, and they have the freedom to exercise a lot, and when they're stressed, they have people to talk to, and they have a lot of good self-care in place. How they move, right, in the world is a little bit more supple than somebody who's had a very hard life and not a lot of support, and you know they've gone through a lot of trying times, and they don't have people to turn to. You can just imagine how their spine is over time, right? This doesn't take a lot to call up in your mind's eye people that you know that already embody the way that their life story has gone. And so the physiological discharge of all of that stored survival energy is what we're talking about here. So it can happen in relationships that people need to defend, or it can happen because of other environmental factors that people need to defend and then can't really. So it's just held. Does that make sense?
Great, thank you. Our next question, what modality is most efficacious for complex PTSD in a mature adult?
Well, the data will want to compete with you on that. So what I would say is I don't think that the field of traumatology and trauma resolution has been around long enough for us to say this is the go-to modality. I really think that clients' constitutions are going to currently, right now, with the way that things are, direct what would be most helpful for each and every client. So children are going to be different than older adults. Folks who've experienced, say, sexual abuse at the hands of family members might be different than folks who've gone to war, right? I think that practitioners who get very passionate and excited about a particular modality say this is the one. And I think that's just, you know, when we invest a lot of time and energy in becoming educated in something, there's an investment in that being the one. And so what I would encourage you to do is to maintain openness and curiosity about where you feel drawn to work. And if what you're really drawn to is a particular modality, then training in that modality will direct who you're going to be able to help. And if you're really drawn to a particular population, then working with that population will dictate what's going to be helpful for them. So for instance, if you're working at the VA, mostly with, say, older males, I don't think that dance movement therapy is going to necessarily be the modality that they're going to want per se. It's possible, but it's not likely that that is going to be as big of a draw for that particular population. A lot of research is starting around EMDR, and I have some concerns about the level of training that people think that they can get and then just rush in and apply EMDR. I think that it's being used a little bit haphazardly in some cases, and so there's a caveat for me around that one. I think that dialectical behavioral therapy is something where there's a growing body of evidence around that. There's a lot of structure to it. You can get handouts, and that can help guide you in how to do it. So that's a safe place to start. Learning sensory awareness and learning mindfulness-based stress reduction are relatively easy skills to use for our own self-care and also to implement. And so that's another nice place to start, where you don't have to go out and get a formal certificate. And you can work with just about any client and have a starting place for just inviting the client back in the body. And then, directing clients to trauma-releasing exercises, which you can view on YouTube online, is another way to go. Rather than feeling like you have to do it all, you can help clients find resources that are available for everyone. So I'm not in a position to say what is the best one. I think that it really depends on the developmental and chronological age of your client, the kind of trauma they've been through, what their current level of safety is with their own body and with their clinician, and what feels congruent and genuine for you as a practitioner in terms of what you could actually hold as a container. Some folks will be much more comfortable teaching a few self-regulation skills in a really structured way, where other people would really like to dive in and be the person that is helping to facilitate discharge after discharge. It depends on the clinician's constitution.
Great, thank you so much. Our next question, can you give some information about psychosomatic illness in children?
There are reams of research around that. Psychoneuroimmunology would be the place to go if you wanted to look at articles about psychosomatic illness. Psychoneuroimmunology teaches about stress pathways. So each body comes in with its own genetic predispositions, and then all of our environmental experience, so the genetic predisposition is our nature, and then we have this whole environmental experience, life, which is the nurture, if you will. So we come in with genetics, and then the epigenetic experience, the nurture experience, will flip on switches. So if your genetic inheritance leads you to be born with tendencies towards illness in certain places, then when you are distressed and catecholamines and cortisol and adrenaline start coursing through the body, the tendency is to hit the epigenetic switches along those genetic pathways. And so that creates what's called a stress pathway. And there's actually more apoptosis or cell death along the stress pathway than in other parts of the body where the genetics are not so fragile. So some kids will manifest asthma, other kids will manifest headaches, other kids will manifest stomach aches, and there can be other forms, of course. So we all have the same places in our human apparatus that we got at birth or got at conception. We all have the same places where we can experience stress, but we have tendencies where stress goes. And what happens when there's more apoptosis along our stress pathways is that those parts of our body, those organs, those systems age faster than the rest of our body, because the inflammation from the catecholamines and the cortisol and the adrenaline break down the cells there faster. So those places get older than the rest of us, and then they become more likely to manifest our stress. And so by the time we hit middle age, we know, okay, this is what happens to me when I'm sick. It hits my lungs, or it hits my stomach, or whatever the experience is. So when we see that happening in kids, their body is telling us that they're overwhelmed, they're distressed, and so we can still use our relationship to help discharge and regulate that experience, and we can use, books like this to help us know how to facilitate that in our talk therapy session.
Thank you. So speaking of that, I think this question is back on co-regulation and healing attachment wounds. The question is there a general time frame in the normative bell curve for neural circuitry to rewire? Does the healing process, and the second question, does the healing process ever cause re-traumatization?
Okay, so if we are not skilled with our intervention, of course, we can open up something and not know how to finish it, right? And so that's where we want to be really attuned. We want to go in slowly and gently. We don't want to go in faster than we are ready. We don't want to go in faster than our client is ready, and it's always safer to go more slowly than more quickly. All of our trauma and crisis counseling students read this book as a requirement in our trauma and crisis counseling class, The General Theory of Love, it does a lovely job of explaining how we need repetition in order to not rewound and in order to make these changes. So the Erin Secure attachment literature looks at a 5-year window for people, which of course doesn't have to be just us. We could set somebody up to be able to find a secure relationship out there in the world, and then they can go and have it. That's one way it can happen. Or if we work long-term with somebody, we may need to bear in mind, if they're coming from a really insecure place, they might need 5 years of bringing their discharge to us and us grounding it for them and showing their nervous system how to do it before they're able to do it. So the real trick here, and this is on your slides, so you don't have to try to memorize it, is that it's left eye to left eye contact is what allows your limbic brain crossing with the optic nerve over the corpus callosum out your left eye into the left eye of your client to use your nervous system as a template for how to regulate in spite of overwhelm, how to complete overwhelm and how to discharge it. So it's another one of the reasons we want to encourage that when our clients are starting to go into that really overwhelmed place, that they stay with us and that we try to offer them gently this loving eye contact so that their nervous system can start to pick up through the optic nerve what our nervous system is doing. So I can't give you the easy answer about that because depending on the quantity and the duration and all of that of the trauma that someone is carrying, it will be longer or shorter depending on, how much resilience they still have easy access to and how much they're going to have to develop because of what they're holding.
Thank you. Another question, could you talk a little about prenatal exploration?
Sure. So pre and perinatal psychology has a lot of wonderful specialists. That is on the reference list that is coming to you in the PowerPoint 2.0. Pre and perinatal exploration invites us to shift out of our logical, linear, verbal processing because our experience in utero is pre-verbal, right? And it's in our implicit memory, which is stored in the right hemisphere of the brain, and it's also stored in the body. And people that are trained to work from a pre and perinatal perspective notice movement, notice patterns, and they use reflection to help a client shift from the defense of intellectualization and verbal processing into the felt experience. There are a number of people working in the world that specialize in kids who were adopted and experienced prenatal trauma and have difficulty attaching because of the prenatal trauma. And once they work with and validate what the baby experienced in utero, the babies are able to move that out and then attach to the caregiver that they are given. And so that's one way to do it. There is adult group work where it's an all-day container that's held, and the facility will allow for each person to claim when it is their turn. And because of how they are trained, they have the facility to help this person complete whatever energy from the birth process feels like it's still stored in the system. And it's fascinating to experience, and it's fascinating to watch. It is amazing what a skilled practitioner can pick up about someone's birth story based on how they are moving, what it is that they are finishing. Craniosacral is another way to do that. Craniosacral practitioners are trained to go back to conception with how they work with the body. And so they can sense, based on what's happening with some physiological measures that they are tracking, when somebody is shifted into that really early implicit memory. And they can help bring that up into explicit awareness so that there can be conversation about it, validation, and discharge.
All right. And I think the last question we have time for today, did the modalities and treatments that you've talked about today apply to pain management? Mindfulness-based stress reduction is used in hospitals and schools and clinics for chronic pain management. And I strongly recommend taking a look. You can just Google MBSR and find all sorts of different books and speakers who do free guided visualizations that you can stream on YouTube. Thich Nhat Hanh is one of them, and we already mentioned Jon Kabat-Zinn. You can find practitioners that work with a voice that your clients really like. That's a wonderful way to help have the pain speak to the client and give information to the client about why the pain is there and what it's trying to say, and give it space.
and also create some room for the pain to keep moving through the body so that it discharges. In addition to some of these body-based modalities that really are about getting into the body and helping to shift what's happening with the connective tissue or the muscles, and psychospiritual embodiment practice, which is the client going to a class like Tai Chi or Qigong or yoga or Watsu or what have you, and learning to move in a way that helps to release this energy from their system because they're being led by somebody who knows how to do that. That's a really important resource for clients.
All right. Well, thank you so much, Dr. Ross.